Thank you very much, Chris. Good afternoon, everyone. My name is Jitenga Knox, and I am the Administrative Assistant for the Multi-Interprofessional Center for Health Informatics at the University of Texas at Arlington. Welcome to today's student presentations. The session is titled Student Involvement in Combating COVID-19. Our first student presentation will be given by Nicole Cevallos. Nicole is a public health student at the University of Texas at Arlington with a research interest in health informatics. She will be presenting her talk, The Association Between COVID-19 Related Stress and Demographics Concerning Social Determinants. Thank you.
Hello, everyone. I hope everyone can hear me well. Thank you. I'm thankful to be here. So today I'll be talking about, like Jitenga said, the association between COVID-19 and stress and demographics in relation to social determinants. So the experiment was conducted, focused on identifying, again, the association between COVID-19 related stress and demographics among students between the ages of 18 and 25 at the University of Texas at Arlington. Those students were usually juniors and seniors and about like a couple of sophomores. And the purpose was to identify whether there's an association of practically for mental health. So the methodology included a survey. So me and a couple of colleagues used Question Pro to develop about 32 questions. And it went over demographics and symptoms of mental health or a diagnostic of COVID while having some sort of mental health correlation. And then we did cross-sectional survey design, which targeted the students at UTA. And then we collected data that was exported from Question Pro after the survey was closed. We opened it for about like 2 weeks. And then we did data cleaning, recoding, and we used Excel for that. And then we had a linear regression, independent tests, and descriptive statistics. So the results were 31 students, and then over half of the participants were female, which 87%, 61% were seniors, and then 52% of the participants were white. And then between the ages of 18 and 25, which was 84%. So we had to do a little bit of a screening. For the 3 t-tests, we ran multiple independent tests. Our first independent test showed no significant difference in overall stress levels between juniors and seniors. So the p-value was 0.07. Our second independent t-test showed no significance difference in overall stress levels between Hispanics and non-Hispanic students, which was 0.230. And then our final independent t-test showed no significant difference in overall stress levels between white and non-whites, which is 0.103. Our groups also conducted linear regression analysis and the correlation between demographic variables, and perceived stress levels was not significant, and that would be due to the fact that it was a little group. And so this is a visual representation of all of what I just said. So yeah, the majority of participants indicated that they were currently stressed due to schooling, socioeconomic status, due before COVID. And so some of the strengths and limitations from the experiment includes, during COVID, you had limited in-person communication. So online platforms really did help. Like even if we did have an in-person, surveying, we still were able to reach out more individuals through online platform. And then we encompassed in our survey different mental and cognitive health related symptoms, situations, And then we collected a variety of background for the participants at UTA. They had a wide background. And then the limitations, well, one of the main big limitations was it was a small amount of participants, and that would be because we focused on UTA students, and that was most accessible, but at the same time that was the more limiting because you know, you can just walk by to your neighbor and you know, ask them a question, or you know, send out platform links to other individuals that weren't in UTA. And then we also focused on the participants being public health majors, just because we thought it would be easier or more beneficial if they had a public health background, just to know what's going on. And then the topic was fairly new because at the time that we did do the research, COVID had just come out. So we did have limiting research overall. So, you know, vaccine wasn't developed, and the research for, you know, variants was barely coming out and barely being published. And then the timing of research, you know, correlated with how new it was. And then the lack of students who who did not reported mental health symptoms. So some of the students that did report symptoms were self-diagnosed. So the credibility in that one was a little bit like undefined almost. And so the conclusion is overall 81% of the sample students felt stressed overall. And then COVID did affect most students regardless of demographic variables. So, you know, ethnicity or gender. Therefore, more effort should be contributed towards mental health on campus or just in general. Lessons that I did learn, recapping on the whole thing, is not enough participants really did affect the outcome. So like for instance, the p-value. And then more research has been out there recently, but I still think it is important to put out there more mental health and COVID together, implementations to be developed. So for example, you know, the idea of misinformation kind of stressing everyone out, or the some perspective that people have over the vaccine, that can probably also cause some sort of stress, which can temper with mental health. And then culture really did define mental health, or what, you know, a certain ethnicity defined mental health versus another. So you did see a different perspective for sure. And I would also like to thank the host and, you know, other panelists and audience and everyone who contributed to this conference. It made a very well conference. I learned a lot, so I'm grateful to be here. So thank you very much. And then these are references, and then any questions?
Okay, thank you so much, Nicole. Unfortunately, we do not have time for questions right now. So if there are any, please definitely feel free to shoot them in the Q&A or within the chat, and we will be sure Nicole gets those. Our next speaker will be Debra Graham, who is a healthcare professional anchored in nursing science with over 25 years of acute hospital, clinical, and healthcare information technology experience. Debra is in the third year of her pursuit of nursing practice at the University of Texas at Tyler. Please take it away, Debra.
Thank you. Thank you very much. Let me get my share. You were very fast.
We're on a time frame.
You're on it. On it. Okay. And I even practice, but you can see my I'm missing that second share.
We can see your slide.
Oh, I don't want, you can see my,
We can see your desktop.
now,
Let
how
me see
about
your
that?
slide. It looks
Yes,
Thank
now we see this.
you. Thank you all very much. Thanks for your patience. Not my first webinar, but obviously the gremlins have happened today. Thank you all. In the next 10 minutes, I want to share with you the implementation barriers we experienced in the use of technology to meet a clinical need and the impact on the bedside nursing staff and patients. And these are my objectives. I want to please come with me on this journey. This morning in our keynote, our keynote talked about at 9:42, she leaned in and said, "Don't forget long-term care." And it set the stage really well for this presentation. And I'm going to touch on some of those things. And from the heart of a nurse and an advocate of a nurse, of what is happening in long-term care and health information technology. So we know that 1 in 5 patients go back to the hospital. This is a given. I work in an organization that supplies physicians and providers to long-term care in the Panhandle in Florida. And so we were struggling with that early 2020. What could we do to improve that as providers? And then we found that we were very effective in using telemedicine in the care of COVID. So in an evidence-based practice mindset, I looked at that and said, wow, this is working really well for us, telemedicine in the treatment of COVID. What can we do to apply that to look at this problem for readmissions and visits to the ED? And there was plenty of evidence. You can look in my references, and we had a multidisciplinary team. We followed project management. I really did lots of things right to get this ready for deployment. But this is what I want to share with you is when the obstacles about January of 2020, the obstacles became so apparent to me, and my success was really hampered when I discovered this. And our keynote alleged this, or that Nora Belcher said this morning. We are not provided the same level of care. We didn't get any incentive dollars. My previous speaker, so mental health, we didn't. Acute and ambulatory did. So because of that, we didn't get many of the tools. But we're held to the same HIPAA standards and the CMS standards and penalties without the tools to do them. So my organization is doing a great job. They have an EMR, health IT systems, interoperability, but we are still at such a disadvantage digitally. We didn't get stage 1, 2, and 3. You can't even run an audit in the EMR as a user. The EMR can do it for you. Open a ticket, ask them for what that user did, and see how long that takes to get it back to you. You can't do it yourself. So because of that, in policy, we have further restricted our staff because we have to meet all of these guidelines and standards. So now I want to look one at a time then at some of the barriers. And again, full disclosure, I caused some of these. I didn't realize what I was doing to my tribe, to my people. These are the people I work for and advocate for as a nursing informaticist. They don't have email. Most long-term care staff members, now, the supervisors, directors, etc., they may. But this is Greg Alexander's done lots of research here. He's well published in this. That my experience in Texas, where I'm in school, and in Florida, is they don't have a direct, secure email to those staff members. They have multiple things to keep track of by ways, as many as 10 different systems between pharmacy, x-ray, lab ordering, their EMR, payroll, schedule, their computer-based learning system. All of that, none of it is organized in an Active Directory. We could spend an entire presentation on bring your own device. It's very inconsistent and it hobbles the staff. Internet Explorer 11 is a plague upon long-term care, and it was one of the biggest barriers that we had to address and overcome. This is a conglomeration of some unintended consequences. So all of those I listed. So what do we do when left with situations that make it very difficult for me to do what I'm supposed to do, which is care for my patient? So they share, they post them, they use each other's, they do workarounds. We took their most common mode of medicine, the phone, and said, Uber your doctor. They'll show up in telehealth. Isn't that cool? Well, it's not. If you can't remember your password or your username and your URL is not compatible on the desktop that you're assigned at the workstation you're working at, and you don't get to use your own phone because it's against the policy, so you have to run back to the desk when they call back. So one more thing happens every day. So what the response is, lack of adoption. They just abandon what your system invested all that time and money in. And sadly, the patient outcomes fail. So if in summary, if I was the wizard, if I could help everybody reimagine some solutions, it would be fabulous. If we could have some sort of, this is a little local, I guess, within organizations, but just, a single sign-on would be great. But is it time to look, will our national nurse ID, can that help us in some way? Can blockchain help us? Can there be cloud-based some sort? Can I have a Debra Graham bank of all my secure emails that they all get delivered there? What do the travel people do with all of this information? And when you don't have a good way to do it, you'll text it. You'll take a picture of it on your phone. You know it's wrong, and you know you're not supposed to. But we are called to serve, and that's what we'll do. Adopt policies and make up our minds, please, on this devices. And it's not just phones. It's computers, it's iOS incompatibility, it's Android, it's the video software. It's all over the place. So vendors, please look at that. Invest in infrastructure of optimization. Don't use a lab system because it's cheaper that only works in Internet Explorer 11. Look to the future and require your vendors to upgrade with you. One tip I have is to have, when you're investing in a solution and you're vetting things, can you put in your contract that you want to be a referral source? I've lived on that side too, audience. And if you are a contracted referral source, that vendor will be very interested in keeping you happy. So bargain to get more for your people. And we know in both the Institute of Medicine reports, that Future of Nursing, the 2011 one and now the 2021, they advocate that to improve the lives of nurses and influence that workflow, that frontline staff must be engaged as evaluators of our systems. I thank everyone involved. Ms. Flannery, if she got as many questions from all of you as she got from me today, God bless her. I really thank the time and attention to it. This is my information for contact, and I thank you very much for this opportunity to bring to your attention the plight of the bedside nurse in long-term care. Thank you.
Thank you so much, Debra. Now, again, if there are any questions, please send those to the Q&A or the chat. And lastly, it is my pleasure to introduce our last presentation for the student session, which will be given jointly by Mercy Obasanya and Anna Aleksandric, who are both graduate research assistants in the Multi-Interprofessional Center for Health Informatics at UT Arlington. Thank you.
Can you see my screen?
Everything
Yes,
looks
we
great.
can.
Okay, hello everyone. My name is Anna.
Hello, everyone. My name is Mercy, and today we'll be talking about your tweet matters, how social media sentiments associate with COVID-19 vaccination rate and vaccine hesitancy. And for this research project, our research advisor, Dr. Shireen and Dr. Gabriella. And so how has COVID changed our life? COVID has changed the way people used to travel, dine in restaurants, work from office, even education. And we know that from in 2020, we had some mandates based on COVID. So wearing masks, social distancing, working from home, and schooling from home. And in 2021, the vaccination started to roll out in the United States. And so we started to see social media interaction and social media thoughts on the vaccination. And so our project was to look at how social media sentiments, neutral, positive, and negative, affect vaccination rates in the United States. And so we collected vaccination per 100 people and averaged it for each state. And we collected those vaccination rates between January 4th and May 11th. We stopped at May 11th because the Delta variant started to come up during May, and we didn't want that to affect our data. We just wanted to see what the vaccination rate looked like before Delta variant. And we could see that for each state in the United States, there's different vaccination rates, and this could be an influence of multiple factors, multiple social determinants of health factors. And so we looked at two social determinants of health variables to consider as a factor in our research. And one of them is health literacy, which is the degree to which an individual has the ability to find, understand, and use information to inform health-related decision. And then we also looked at social vulnerability index, which refers to the potential negative effects on community caused by external stress, and an external stress would be a disease outbreak such as COVID. And we know that low index means that the community are at risk, especially during a public health emergency. And the reason why we went with these two variables because health literacy we know influence health outcomes, and social vulnerability index combines four other social determinants of health variables such as socioeconomic status, household composition, minority status, and the housing type and transportation. So we wanted to look at how these two factors influence vaccination rates in the United States. And so our research question for the project is, one, is there an association between social media sentiments that we saw between January 4th and May 11th and associated with the COVID-19 vaccination rate in the United States? And what are other contributing factors that could affect COVID-19 vaccination rate and the vaccine hesitancy in the United States?
Okay, so I will briefly go over data collection and cleaning process. So we started off with the COVAXI dataset, which is a collection of vaccine-related English tweets collected from January 4 till May 11 using special vaccine-related keywords. And we also only extracted tweets posted within US. Afterwards, we used FCC API to get a state and county of each tweet. Then we used Humanizer to remove tweets belonging to organizational accounts. Afterwards, we use Botometer to remove tweets belonging to bot accounts, or in other words, accounts which express automated activity. And finally, we used Vader to get a sentiment of each tweet. So sentiment scores ranges from -1 to 1. Scores which are closer to 1 means that the tweet is more positive, while if the score is closer to -1, that means that the tweet is more negative. So now I will describe the results that we obtained from our statistical analysis. So we run linear regression models to try to find whether there is any correlation between vaccination rate, health literacy, social vulnerability index, and tweet sentiments. So you can clearly see from this table that each of these variables have a significant correlation with the tweet sentiments. For example, vaccination rate and health literacy have a strong positive correlation with the tweet sentiments, which means that a higher vaccination rate and higher health literacy are correlated with the more positive tweets. On the other hand, you can definitely see that there is a negative correlation between social vulnerability index and tweet sentiment, which means that a higher social vulnerability index is correlated with the more negative sentiments. In order to visualize these results, we picked 3 states, such as New Hampshire, which was one of the top 3 states with the highest health literacy and highest vaccination rate and also lowest social vulnerability index. We also chose Mississippi, which was the state with the highest social vulnerability index, lowest health literacy, and lowest vaccination rate. And we also picked Texas just in order to see how Texas stands compared to these 2 states. We ran man witness tests to compare whether there is any significant difference between tweet sentiments in these 3 states. So what we found is that there is a significant difference between tweet sentiments between tweets posted in Mississippi and New Hampshire, and also between tweets posted in New Hampshire and Texas, while there is no significant difference between tweet sentiments with tweets posted in Mississippi and Texas. So if you actually look at these graphs, you can definitely see these differences. For example, on the left side, you can see that Mississippi and Texas have very similar social vulnerability index and health literacy, while it's quite opposite for New Hampshire, having very low social vulnerability index and pretty high health literacy. On the right side, you can see that sentiments and vaccination rates are pretty similar for all these 3 states, in a way that New Hampshire has much more positive tweet sentiments and also much higher vaccination rate, while Mississippi and Texas are having lower sentiments and also lower vaccination rates. The other factor which we think that it might have an impact on these differences in sentiments and vaccination rate between these 3 states might be racial demographics. So what we did is we extracted the data about the racial demographics of these 3 states, and you can clearly see in this table that there is a much higher percentage of minority populations in Mississippi and Texas compared to New Hampshire, which might be the reasons why we saw that there is a very big difference between tweet sentiments and vaccination rates in New Hampshire compared to Mississippi and Texas. So in conclusion, the correlation between sentiments and vaccination rate reflects the important role played by social media in public health intervention. Health literacy and social vulnerability index need to be considered in public health interventions and vaccination campaigns. Finally, vaccination rates are strongly associated with social determinants of health and social media sentiments. And thank you for your attention. Why not changing? Yes, so if you have any comments or questions, feel free to email us about it.
Thank you so much, Anna and Mercy. I will now direct you to Dr. Gabriella Wilson and Dr. Susan Fenton, who will be your next moderators.